here.
Mm-hmm.
Well,
Okay.
um, uh, one thing she told me was that she's been sending me a few patients, and one of them, the way we measure things, I gave the patient curcumin, and she told me that curcumin destroys estrogen,
Oh,
and
it's a aromatase inhibitor.
it's yeah. So okay,
Right. Okay.
oh there we go.
So I fall in that category.
Yeah.
Okay, okay, so I decided to call this the specter of estrogen dominance because it's no simple thing. It's really complicated. So I want to go back to two pioneers, Dr. John Lee and Dr. Katarina Dalton. So here's John Lee and his natural progesterone book. John Lee, toward the end of his career, depending on Dr. Ray Peat's work, used progesterone, and he didn't use large doses, 20, 30 milligrams, I forget, in 100 patients to treat osteoporosis. And he reported positive results, and he went on to write this book. And I do recommend, if you've never read this book, it is a good foundational book. And he's the guy who defined estrogen dominance. So it's a ratio of estrogen to progesterone, and it doesn't mean that estrogen is particularly high. It would just mean that progesterone is lower. So it's defining the relationship between estrogen and progesterone that he was talking about. Now, John Lee was very adamant that you only needed about 20 milligrams of progesterone. That's what the body produced, and that's all you should use. And he quickly embraced saliva testing, which sort of reinforced his low dose of progesterone treatment. And we'll go on because I did a deep dive looking for this evidence of 20 milligrams of progesterone being produced. And I finally went back to Ray Peat and asked him, and he didn't offer me any proof for the 20 milligrams. He did offer a proof for over 100 milligrams in the uterine vein. And progesterone is produced all over the body. It's not just produced in the ovaries, it's produced by the adrenals, it's produced inside cells, and we'll go into that. And then here's my hero, Dr. Katarina Dalton. So she started publishing long before the 50s, but this was her book, Once a Month. And she characterized premenstrual syndrome, PMS. And she had tons of symptoms being related to this premenstrual syndrome. And sometimes it could get quite severe. PMS could have suicidal tendencies. You could have homicidal tendencies, extreme headaches. These were some very serious cases, seizures that were identified by her and treated with progesterone. So she was talking about how these progesterone receptors were all over the body and explained the vast difference in symptoms that women were getting during the luteal phase. Her treatment was generous doses of progesterone. She started out with injectables. She then moved on to vaginal suppositories. The strength of these would be 400 to 600 milligrams. You might need more than that. I started working with Women's International Pharmacy, and we were compounding, and using her philosophy, we were doing a compounded progesterone in oil. It was before Prometrium came out. We used safflower oil first. We switched to olive oil. And the dose for luteal phase, PMS, was a starting dose of like 400 milligrams, one capsule 4 times a day. And very quickly, we found with the many practitioners working with these women, we might need a lot more. We called it breakthrough. When women did not have all their symptoms relieved by this dose. So more and more things got compounded. We did rectal solutions, we did suppositories, rectal suppositories, vaginal creams, topical creams, lozenges. We also sold the injectable. So I've seen doses in those cases up to 2,500 milligrams was the largest I could remember. But realize this, for the most part, women got relief from their symptoms with these large doses. So we have, you probably all recognize this chart with the menstrual cycle. And if you look at progesterone, it doesn't look, it looks insignificant in the follicular phase and barely topping estrogen in the luteal phase. But the units are in picograms for estradiol and nanograms for progesterone. So in your mind, please, move that black line for progesterone 1,000 times up. And suddenly you're going to realize how important progesterone is, not just the luteal phase, but both part of the menstrual cycle is very dependent on progesterone. I put these in here for some numbers. So on the left, it's in nanograms. On the right, picograms for estrogen. Left is progesterone. So those numbers should be multiplied by 1,000 to be in the same units. So here are some of the signs we recognize. You'll find this on drug inserts from the FDA, some of the signs of side effects of estrogen products or just excessive estrogen in the body, breast tenderness, headaches, leg cramps. Diminished cell oxygen, I think, is an important thing to think about. We don't really do that. Vaginal bleeding, I'll say more about that later. It's an issue, it's a big issue. And we'll go on. So after I left Women's International Pharmacy, one of the things I missed was speaking with patients and helping them solve their problems and answering their questions. So I took myself to Facebook, and there I found what I was looking for, because what I was looking for were the failures. Too many practitioners lose track of their patients, and they think they might be doing a good job, but they're not. And there are women there who have seen multiple practitioners who've been unable to help them, and they go from practitioner to practitioner. And it's abysmal. On one of these Facebook pages, this is a very popular page. It's run by the CEO of ONAS. ONAS is an over-the-counter, has over-the-counter products with hormones. The Estrogen Dominance Support Group. And this is published in the group, but this is a very important concept. And I brought this to them. They call it estrogen kickback. So for lack of a better word, we'll use that. So when you use a tiny dose of progesterone and it's not enough to really balance or really give you all the progesterone you need, one of the things that happens is your estrogen, and now I think maybe adrenaline too, activity gets enhanced. And so many women will be out there saying they can't stand progesterone, they can't take it. I sent them to the hospital with panic attacks, heart palpitations, 20 milligrams, 30 milligrams. This is not infrequent. Now, John Lee liked to recommend a product called Progest. It was 16 milligrams at the time per dose. And we at the pharmacy we're selling it, and we found this was problematic, this very kickback kind of thing. But we also knew from our work with Katerina Dalton's guidance that this was like the breakthrough. You need more progesterone to fix it. And so we would talk to women and recommend that they talk to their doctors to get more progesterone than they were using. Dr. John Lee addressed this at one point. I heard him at a conference in New Orleans, and he said, oh yes, women are complaining of issues with the progest, but just continue to use it every day, and in 9 months, all will be well. Well, I don't know about your patients, but none of my friends would would settle for that. And then we knew, because of the breakthrough PMSers, that we can resolve this in hours. Just give more progesterone. Another thing that's kind of interesting, I pulled this off the website. Look at estrogen and progesterone is deliberately misspelled. This website, this Facebook page actually was challenged for recommending progesterone. So I'd like to introduce a case study we'll talk about at the end. This is Janelle. She's 45 years old. She's had a hysterectomy, bilateral oophorectomy. The diagnosis of PMDD puts her in a certain protocol, and you can look at Wikipedia and find that protocol. Interesting enough, the word progesterone is never mentioned there. So this happened in the late 90s. Prozac's patent was running out, and they searched to find a new indication that they could have approved by the FDA. So they did a study and reported that 50% of the women in the study with these emotional symptoms of PMS, which they now renamed PMDD, would respond to SSRIs. So Prozac was approved for that. And it's kind of an interesting story because PMDD they got an approval for PMDD before it was actually defined. So there's a lot of shenanigans going on there. So the next thing you try is birth control pills. When that doesn't work, gonadotropin blocking agents like Lupron to shut everything down. They try that. And then the final solution is that you have surgery, you have your oophorectomy, because you are too sensitive to progesterone and you want to avoid progesterone at all costs. So what happens to somebody then? We all know this. Women with oophorectomy are given one hormone back. So our person here, Janelle, she had estrogel. She's suicidal, she's anxious, she's angry, tender breasts, insomnia. She gets offers of benzos, antidepressants, sleep agents. She's got hypertension. And nobody is going to help her with progesterone. She's going to be readily drugged, but they're not going to touch progesterone. They're going to withhold progesterone from this patient. And these are some of the most complicated patients that you will come to your practice. So what's that progesterone doing? Like John Lee said, multiple roles. So it does balance estrogen. It is said that it's happening at receptors with estrogen receptors and progesterone receptors. I don't know if that's the only thing. I don't know if it's a yin-yang situation. I don't think we're really clear on that. Progesterone is a precursor to the corticosteroids. So hydrocortisone, cortisone, and all of the other derivatives can be made from progesterone. And so if you've been adrenally exhausted, you might have great deficiencies going on there. Some people call this the pregnenolone steal, which was defined as pregnenolone sucked up right into the corticosteroids. I don't know if there's evidence for that either. So progesterone can balance low blood sugar, can bring a low blood sugar up. And some of this may be involved in adrenaline. Adrenaline goes up when blood sugar goes down. Progesterone has independent synthesis in the Schwann cells along with pregnenolone. It's made de novo from cholesterol in the brain, and it acts as a neurosteroid. It's your body's aromatase inhibitor and 5-alpha reductase inhibitor. It's made in mast cells. We have the whole hormone factory in the mast cells. And there's the sense of endocrinology. This is particularly important after menopause. All these hormones being made inside our cells and not directly from an organ. And it has antioxidant and anti-inflammatory qualities. So on the other side, we have a lot of things contributing to problems with estrogen. So we can have methylation deficiencies. So we're not detoxing estrogen very effectively. But keep in mind that methylation is the primary detox mechanism for adrenaline as well. The estrobiome, we have bacteria that can produce estrogens. We have enteric hepatic recirculation of estrogens when some bacteria produce beta glucuronidase to cleave off a conjugated estrogen, goes right back into circulation. We have xenoestrogens, all these outside estrogens that we find in insecticides, pesticides, metalloestrogens. Heavy metals can sit on hormone receptors. Then we have fungal production. Saccharomyces cerevisiae produces 17-beta estradiol, for example. Glyphosate is estrogenic, and it's prevalent all over the place. We even have tests for glyphosate burdens these days. Growth enhancers in meat. Cattle are actually injected in the ear with 17-beta estradiol. Dr. Al Pluckner was a veterinarian, and he claims he found this immune system nexus. He would test in animals and then humans. He tested about 2,000 humans with looking at total estrogens versus IgA, IgM, and IgG, and beta cells. When those were down, the immune complexes were down and total estrogens were high. He said this was a symptom of a disconnect here. And interesting enough, the correction that he used was hydrocortisone. Estrogen therapies will give you extra estrogen, of course. So here's just one paper on progesterone synthesis by itself in the nervous system tissue, in the Schwann cells. So that hormone never gets measured, and it's not going into general circulation. It's produced and used right there. Neurosteroids in the brain, as I mentioned before, they're created in the brain de novo from cholesterol. The nice thing is that when you use hormones exogenously, they also go through the blood-brain barrier so your body can use it. But otherwise, these hormones are made in the brain. Okay, this is a book by Dr. Michael Platt, Adrenaline Dominance. And so I began thinking, one of the things we were thinking about this estrogen kickback is like palpitations, panic, severe panic. And I began thinking this might not all be related to estrogen. It may be related to adrenaline as well. And I think there's another little interesting piece here. I've been studying adrenaline, he says, goes up when blood sugar goes down. It's a mechanism to bring more blood glucose to your brain. The trouble is, I believe, back with the methylation issue, when patients are unable to bring that back down. There was, I think it was Melvin Page, but it could be another one. Back in the 30s or so, there were some dentists who are really endocrinologists. He called this thing liver insomnia. And liver insomnia would occur when you wake up in the wee hours of the morning and your mind's busy and you can't go back to sleep. He recommended that you have an apple by your bedside and eat the apple, and you could go back to sleep. So what was that apple doing? It's bringing your blood sugar up. The need for adrenaline is gone. And so that might be a tie-in in what's happening. So there are many people with this kind of adrenaline goes up and it's not shutting down. Now, I've been asking people when I'm talking to them, I do some consulting, and I've been asking when this comes up once in a while. I may have some test results with homocysteine, which can give us a hint, but many people know MTFHR has been measured, and they know they have methylation issues. So I think this is part of the problem that we might be thinking is estrogen dominance. This is really interesting. We don't think of progesterone as an antioxidant. This is a really interesting paper, if you would like to look at it, about the possible use of progesterone for retinal diseases. And it shows that it increases antioxidants like SOD, which could be very helpful. Dr. Ray Peat, who I mentioned before, so progesterone is a basic brain protective anti-estrogen. So it works on many levels in the brain, as you can see, as he's saying. He also mentions vitamin E, like progesterone and aspirin, all act to prevent inflammation. So damping down oxidation. He also has, in some of his newsletters, talked about using prolactin as a measure of tissue estrogen. We have many ways to test hormones: saliva, serum, urine. Now we even have tissue tests, but none of these tests tell us what the tissue load is. And if prolactin ends up being a good predictor, I think it's nice. Elevated prolactin is not only dependent on excess estrogen and hypothyroidism, there's other things such as tumors, but something to keep in mind. And if you have excess estrogen activity, this G. Bourne, who has quite the book on hard tissues, bones, suggests that high estrogen levels creating high prolactin in turn could be actually creating osteoporosis instead of the kind of social convention that you need estrogen for good bones. For it actually is indicated for slowing down the loss of bone, but not rebuilding bone particularly. Vitamin E here also brings down prolactin. So it's kind of a confirmation that that you can moderate prolactin with both vitamin E and progesterone. So that's kind of interesting. Might be another tool in our toolbox of what we can help women with. Here's a reference for glyphosate and its estrogenic activity. We don't measure this as a 17 beta estradiol, but we could be loaded with glyphosate. Here's a 5-alpha reductase system, and both progesterone and testosterone are acted upon with this enzyme. So progesterone, when it's in balance, should be giving you a correct balance between testosterone and progesterone and that type of activity. So something to consider. We rarely look at this carefully in men, but look what we've done. We created a molecule called finasteride, which is in Propecia for hair loss, and Proscar for prostate enlargement. So why in the world are we not going right to progesterone, our own natural hormone that should be providing this balance in our body? Finasteride is loaded with side effects, including loss of libido, loss of sexual function, depression, and even suicide. So it bothers me that this is going on so much. So endocrinology, there's a lot of work done at McGill about all these hormones that are made inside the cells, and it's a major mechanism creating other hormones from DHEA, particularly after menopause. And this is really a common thing. Oh, we need to do inhibition of aromatase, particularly when we are giving testosterone, particularly testosterone in men, but realize that glucocorticoids push that aromatase for one thing. So you should be looking at that. And then progesterone is a natural balancer of this process. Here's the mast cell issue. I've been taken to, every time I hear about some new condition or what's going on, I go into the literature and I look at what's the relationship with that particular issue and the steroidal hormones. There are lots of papers with mast cells and estrogen and progesterone. If you have an excess of estrogen to progesterone inside the mast cells, you're going to promote histamine release. So I've listed a few of these symptoms with histamine that may be coming into your office and you identify as a hormonal issue. So it's involved in asthma and allergies, hot flashes, low mood, anxiety before a period, bloating before a period, migraines, dizziness, insomnia. All of that somehow sounds a little bit like estrogen dominance, but it's histamine related. That's the mechanism it's going through. I found this at the last moment. Look at this. Progesterone should be useful treating some of the COVID type symptoms that we've been looking at. And it looks really promising. I did this lecture for Dr. Haas's group, and I had this paper in there, and I posted it on my YouTube channel, and I posted it on my particular page. And guess what? It got tagged with, it's got a big tag over it to go to the CDC, even though it's a published paper in a peer-reviewed journal. Okay, I've referred to one of the big things that happens with progesterone that causes serious problems. And I think it's probably one of the biggest problems is underdosing. And here is the other big problem, dosing with progesterone. If you have somebody who already has issues with candida, progesterone dosing can make those worse. Now, progesterone does bring up the blood sugar. It does suppress some of the immune components that allow you to carry an alien baby when your progesterone goes up during pregnancy, but it also allows for excess candida, which can be also a problem by its interference with hormones in the first place. So I've listed here some general health things that you can attribute maybe to candida. Well, the sugar cravings, brain fogginess comes up a lot when you're giving progesterone, really a lot. Dizziness comes up a lot. Vaginal discharge. Dr. William Crook wrote The Yeast Connection, and he told me personally, if you have any burning and itching, always think yeast. But it's not that you have a yeast infection right at that particular organ. You're having the toxins, the mycotoxins from that yeast being released into that tissue, and that's what's burning and itching. So a woman could go in with burning vaginal tissue, and they do a swab and find absolutely no candida, but the mycotoxins are there, and they haven't uh, um, checked for that. I once counseled a woman who called Women's International, and she was in a wheelchair. She's paraplegic, and she had extreme itching, and she said she wanted to kill herself. It was so uncomfortable. And I said, well, there's probably yeast, but here's something you can do for a temporary fix until you can get the bigger guns in. I said, get a perianal bottle and wash that tissue off every time you're in the bathroom. And this removes those mycotoxins from the tissue, or do a sitz bath. She was always just showered. That tissue didn't get cleaned very often, hence it got so bad. So once we realized that this did work for her, then we could go ahead and work on candida issues. But it gives women quick relief. So if you have any kind of issues, you know, in the luteal phase, in the normal cycle, women are complaining of constipation or diarrhea. This can be because there's some candida involved. Acid reflux, any kind of indigestion. On the skin, hives, acne, psoriasis even, mouth. I was just counseling a woman with a huge amount of allergies and stuff, and I've just gotten her to do 1 day now of extra progesterone. She's feeling better. Her itching is stopping, but she's already noticing the white coating on her tongue. So we know there's candida involved. So PMS, erratic periods can be candida, postnasal drip, and any kind of sinus infection, chronic. If you treat it with antibiotics and becomes chronic, you know there's going to be fungus in there. Likely candida is most frequent. You get all these emotional things. Here we think about estrogen excess in this situation for some of these things, but it might not be that at all. It can be this. And fluid retention as a progesterone deficit, well, maybe so, but it's also tied up with the candida. Weight gain, you can't lose weight when you're out of balance with this. Itchiness, like I said, Dr. Crook had mentioned itching and burning. Tinnitus, that's coming up sometimes when I'm talking to women. So something to look into. This, if you ever hear a weird symptom after you start hormone therapies, think candida first and see if you can find some other symptoms that they haven't told you yet. That's an issue with this. So some time ago, there was a public group. They called themselves the Candida Research Group. The CEO of this group gave me a whole pile of papers, and I thought, what am I going to do with it? And I decided to make a table of all this literature, what the resource is, what the organism is, and what impact did that organism have. So you'll find this here, a lot of things interacting with estrogen and progesterone, different mechanisms. So I give you this more as something you can look at later as you go through this, if you want to go through it again. So I've got about 4 pages of this. Another thing, I threw this in here because we have, again, a supposition that sex hormone binding globulin means that those hormones aren't available to us. And here's a mechanism that's been identified with a lipoprotein called megalin. And this whole complex, the hormone with the sex binding globulin with megalin, can be absorbed into the cell and produce its action. So when we measure sex hormone binding globulin or free hormones, we can't really negate that this also has a function going on. This is also, they call it endocytosis, because the cell just kind of grabs it and takes it in. Okay, just in the last week and a half, this paper was published way back in 1998, and I actually had it on in my computer, and I hadn't paid much attention to it, obviously, but it came up on a Facebook page again. And this was a group of women with PMS symptoms that were treated with potassium, no hormones, but potassium, and got great relief. And I'm thinking maybe this is an area we need to pay attention to as well. Progesterone production is related to the concentration of potassium. And when we do serum potassium, it's a very small amount. Most of the potassium is intracellular. And then if we also have a magnesium deficiency, then we lose even more potassium. The cofactor and coenzyme for progesterone is magnesium as the cofactor and B6 as the coenzyme. So if you are using larger doses of progesterone, it would behoove us to pay attention to these two things to make sure we're not creating another depletion. So because of A4M, I listened to a few talks. So here's a few other conundrums. One speaker talked about unfilled estrogen receptors create inflammatory molecules. And the recommendation was to give small amounts of estradiol, always to make sure you had that covered, or testosterone if you were male. Another speaker talked about potential hormone resistance akin to what we see with thyroid and vitamin D receptor resistance, that you have circulating hormone, but it's not getting into receptor properly. And then another speaker talked about membrane damage, which would damage the receptors. And in this case, recommendation was phosphatidylcholine, also the peptide MOTS-c. Okay, so let's go back to Janelle. What are we going to do with her? Poor girl. So first of all, as I mentioned before, you've got to give her sufficient progesterone. And I counsel patients to use progesterone and use more right away. If you start with a dose and your symptoms worsen or are not relieved, use another dose in 15 minutes and do this till you flip. Your patients will flip into calm. And this happens consistently, and it always seems a little scary. It's very scary for women who've had negative experiences with progesterone in the past, but they can do it if they want. If they want to find help, they've got to somehow get the progesterone restored. You need to stabilize insulin and glucose because of that adrenaline response. And this is another thing, that progesterone acts as a balancer for adrenaline as well. So one of my colleagues told me that her client was wearing a continuous glucose monitor. When she had a hot flash, her glucose went down to 50. So there's probably a tie-in in the hot flashes. Food sensitivities affect your blood glucose, so maybe it should be investigated too. So methyl and sulfur groups may need to be added to the diet or supplemented to help detoxification of estrogens and adrenaline. You might need to do some liver detoxification. Remember, I was talking about the liver insomnia. Part of this problem, the liver is not storing enough glycogen for the night. So maybe a liver detox is in order. Heavy metals, mercury and other heavy metals sit on hormone receptors and block the activity. Could you use antihistamines along with progesterone in some of these cases? And I think yes. And some of those patients may already be on antihistamines, but I would think quercetin and of course progesterone and vitamin C as potentials. Vitamin E spares progesterone, so maybe you can get by on a little less if you also take care of the vitamin E. You can add pregnenolone, hydrocortisone. I did have a couple clients I worked with progesterone, but they didn't seem to make hydrocortisone very well. A small dose of hydrocortisone made a big difference, like according to William Jeffries. Salt to help your adrenals, always good. Vitamin C and B5. B5 is especially used by the adrenal glands. Proteolytic enzymes are situations where we're having a lot of inflammation by immune complexes. And as progesterone is also an anti-inflammatory, bringing down this inflammation, we're breaking up these complexes and digesting it with proteolytic enzymes. Candida protocols, I can't tell you what the best one is. There's so many techniques, and hopefully some of you have some and maybe could have some comments on that. Dr. Ray Peat recommended very highly a carrot salad, shredded carrot, and then with vinegar and oil, coconut oil. And this was taking care of some of the excess estrogen in the gut, helping mop that up. I was in an office for an IV, and somebody was getting an ozone treatment, and on their form indicating what ozone might do for them, says ozone may detoxify excess adrenaline. So I tried to look and find extra information on that. I came up not with too much, but back to estrogen excess, a low oxygen, cellular oxygen state, and maybe with adrenaline too. As I mentioned, potassium, adding potassium to this. And there's a kind of a very special potassium thing I want to share with you. Dr. T.C. McDaniel used to work in Cincinnati, and he did chelation and whatnot, but he used this powder he called Zeta powder. When I first learned of it, I had no idea what it was, but I have found out it's 3 potassium salts. And you do 30 grams of each of those salts to make about 90 grams, and you dissolve that in a liter of water, and then 1 teaspoon a day of that in some water improves your potassium levels. And to my surprise, I found the same triple potassium three potassium salts promoted in Max Gerson's book for cancer patients to keep them alkaline. So when I'm looking at test results, I look primarily insulin and glucose is a main driver in all of this hormone imbalance. And then I look at adrenals. If you don't have adrenal support, you can't really support thyroid with thyroid supplements. And finally, look at sex hormones. This is Bocan Baru and Boquete, Panama at dawn. So I think we're at the dawn of new medicine here, where we actually are working to help patients instead of just drug them with toxic substances. And finally, here's my contact information. Thank you.
Hi, Carol. Loved it. Question for you. I don't know if you know about this. I've been hearing this. Can you hear me okay, by the way?
Yeah, I can hear you. Yes.
Okay, I'm sorry. I've been hearing about this controversy. You know, we all hear about soy and phytoestrogens and all of that type of thing. And maybe I need to be enlightened here, but what I'm hearing is that the phytoestrogens don't really have that similar of a chemical structure to our own endogenous estrogens, whether it be estradiol or what, and actually can bind to an estrogen receptor site, which inhibits our own estrogens. And therefore, they're saying that these can be used for estrogen dominant cancers. Do you know anything about this?
Yeah, I've heard so, and I've actually heard the opposite through the years. And
Oh yeah, of course. Yeah.
there's a big soy council promoting that position. So I would read carefully, very much in any study that promoted it. I'm not comfortable with soy protein and soy products particularly. We like overuse it. We'll do a soy protein powder. It has such negative effects on our thyroid functioning, which in a cancer situation, thyroid is usually suppressed anyway. So it would not be my first choice of thing to do. Some of the other estrogens, herbal type estrogens, also have been in question. Do they block, and is that useful, or are they actually contributing to a problem? So I don't know. It's not really I haven't done enough research into that area.
Okay, yeah, thanks. I thought that was interesting that we've all heard through the years, oh, for estrogen, stay away from soy. And now I'm hearing that that's like a bunch of bunk, that it's not that bad. And I'm sure it's not used to treat anything. They're just saying it's not going to stimulate our own estrogen receptors.
Yeah, and it
I
could
don't
be
know.
dose related,
Yeah,
like
it could be.
soy milk, for instance. I walked into the health food store and the owner's drinking a whole quart of chocolate soy milk. Well, what about her? So
Wow.
what's happening with that? So I don't know. I can't really say.
Okay.
Dr. Patel,
Hi,
how are you?
good.
So you think the PCOs are estrogen dominant syndrome, or they have a problem with the period?
Hi,
And
did you say PCOS?
correct.
Yes. Yep. They may be estrogen dominant, they may not be. It's both. And some think that there's some problem with progesterone receptors with PCOS. I think it could be a dose-related thing too with PCOS. If you don't give enough progesterone, it may not be effective. Progesterone's always down. Testosterone may be up, DHEA may be up, or both. So you have hydrocortisone and progesterone being diminished. But I have heard that estrogen can be high or low in PCOS.
So how would you treat those people then?
I definitely give them progesterone.
And like what dose if they are not menstruating?
High doses, like like the PMS doses, 100 milligrams 4 times a day in oral capsules. Plenty of cream if you're trying that.
Would you do it all throughout the cycle or last 2 weeks?
Just 2 weeks, but sometimes they don't know where they are. So I had a colleague who was diagnosed with PCOS, and she asked me, she had a prescription, got a prescription for 100 milligrams of progesterone 4 times a day. She asked me when she should take it, and I said, well, you don't know where you are, start right now. And when you start bleeding, you can stop. And she did that, and then she cycled for the next cycle with her progesterone. She became pregnant that fast.
What do you do for the high androgens then?
High androgens will come down because luteinizing hormone comes down when you put the progesterone back, or if you have high DHEA, hydrocortisone can be replaced, or you can use progesterone as a precursor.
So do you do the I mean, when you do the the ACTH cortisol test, and it is
Mhm.
normal, but you think at least at the tissue level, it is low.
Yeah, and you still could have exactly, even though that's an effect and seems to be acting, does it actually get to the receptor to the tissue and produce the action? So it's worth trying.
So I have a patient that the gynecologist put that patient on low estrogen, and in 3 months, this poor girl gained 20 pounds, and then she was being blamed that you ate too much. I know her that prior to beginning of this hormone, her weight was 20 pounds less.
Yeah.
Then she had one period, then another one is she had a just the spotting, another period, but she kept on getting the weight gain, and her bra size from normal C size to it increased to triple D size.
Right. So I believe you said low estrogen, right?
The estrogen was not that low, but she was placed on low estrogen, the
Yeah,
butterfly pill.
the birth control pills. So
Right.
so consider this, the progestin blocks your progesterone receptors. You knock out all your good progesterone activity, and you still have, even if it's a synthetic estrogen, usually ethinyl estradiol, it still is giving you estrogen activity. So you've made this poor girl more estrogen dominant with nothing to relieve that. So it's almost predictable. Just got to get off the birth control pill and use progesterone to help her with reestablish normal cycles. And also for PCS, look into low thyroid.
Yeah, but thyroid I manage,
Yeah,
and
but the
so
birth control pill,
it is
yeah,
normal. Yeah, yeah, I
yeah,
have to give her the small amount.
yeah.
The hydrocortisone you think would help her
It
because
would,
it's
but
normal.
not until you get her off the birth control pills.
Yeah, so that's what I told her. She's going
Yeah,
on, but
yeah,
then I said, let me talk to you what where we go from here. So you would suggest to give the progesterone to her.
yeah, definitely. That's what
She's
she's
not even
missing.
an average case. She's with a weight gain of 20 pounds on a 24-year-old. It's just not acceptable.
Yeah, that's what happens to these poor girls. I've been to conferences with nurse practitioners and nurse practitioners who work for the universities in student health. And I ask them what they do with a young woman who's missing cycles and has PCOS. They give them birth control pills and might give them
Yeah.
metformin. That's it. Well, they haven't fixed anything. It just created more problems.
So you mentioned something about MAT-C, so the peptide. So I mean, I use that, and sometimes that helps really good for the glucose and insulin metabolism.
Oh,
And
thanks. Thanks for that.
that is that controls their weight and helps their energy. And
Okay.
the food intake is reduced uh, because usually during the cycle their food intake goes up depending upon where they are. But you don't think the progesterone increases the appetite?
Yes, it will if there's candida over there.
Okay,
And
and if there is no
yeah.
candida,
Yeah, if there's candida, it'll definitely increase appetite.
and if there is no candida,
Then
then
it shouldn't be bothersome. In fact, will be a relief.
so for that candida, you were talking about that carrot salad, but you see, keep them off the dairy and gluten, and keep them on nystatin, keep them on initially some diflucan, keep them off what else?
Yeah, so just as you're saying, there's so many tools out there to deal with candida. So I don't know what the best is. I wish I
So,
did. And um
no, I mean our patients
those are some.
respond
I know
well.
you're, yeah,
Yeah.
I know you're quite spot on.
Yeah. So,
You know, Dr. Morton Teach, probably from AAEM, don't
yeah,
you? Yeah,
right,
so
right, right.
yeah, so he's putting nystatin in every
Yeah,
cavity. So
no, but
that's his tool. He says he
it
prescribes more
helps, but
nystatin than yeah.
it
And
helps, but not for a long period. But you know, even the oregano oil and the hyaluronic acid, all of that they have. So
yeah, they help. So there are a lot of things, and binders help when you're trying to kill candida off, and a diet can help. You certainly want to get people on a cleaner diet. And PCOS, first and foremost, is the insulin glucose dysregulation too. That needs to be fixed. Their diet needs to be fixed, or they wouldn't get themselves in that situation in the first place.
so have you heard anything about use of the spironolactone and that helps that they do not produce a lot of follicles? And
Yeah, I have, but I really haven't done a deep dive on that. Much prefer to use real hormones, not altered hormones.
so have you noticed that after using progesterone in the dose that you're saying that after 3 months, their ovaries, if they do the ultrasound of the ovary, patient would not have a follicles, I mean,
Oh,
except
the
in
cysts on
cyst. I'm
yeah,
sorry, not follicle cyst.
yeah. John Lee claimed that this would happen. I don't have direct evidence, but that once progesterone was restored, the cysts would just pop. I believe it probably would resolve, but I can't say for sure.
Thank you.
Okay, thank you.
I have an interesting question, and it revolves around my wife being in perimenopause with salivary and blood testing showing huge estrogen dominance, and someone that was gravida 8, para, vaginally 6, never having any infection, problem, medication, nothing for most of her life until she became perimenopause for 6 years before actually meeting the definition of menopause. And
Okay, for most women, estrogen is at its highest in their lifespan in perimenopause.
correct. I agree.
So
100%.
she's probably running into that.
Well, no, this
No?
is years ago.
Oh, okay.
We started with low dose progesterone, 25, 50 milligrams orally,
Yep.
of which cause hot flashes
Yeah,
and
it makes it worse.
makes it worse.
Yeah.
And we never did go to these big doses that you're talking about. And I've never seen them used clinically as a compound pharmacist. Not 400 milligrams orally, certainly not 400 or 400 milligrams 4 times a day. I've never seen it use QID.
Okay, but you haven't worked at Women's International Pharmacy, which made our success actually all this progesterone, according to Dr. Katerina Dalton's work, and it's amazing. It's amazing how it works. I've seen it work over and over, hundreds of thousands of cases.
Carol, there was a early on in the anti or hormone world, there was something called the Wiley protocol where they used.
Yes.
Oh yeah, that scared the hell out of me. They came to me and asked me to support the manufacturing of that program.
That was, didn't they use like 800 milligrams?
I couldn't do it.
Oh, I think it was 1600, and I think they went to like 16 milligrams of estradiol at its peak.
Well, the product that they were trying to get me to make topically wasn't even a viable product to put on the skin.
And I personally tried it with our cream base, and I will say all that extra estrogen really feels good. But it was making me fatter, so I quit it. And in counseling some of these women, they start with all that high estrogen and the progesterone can't keep up with it. When they go to use the progesterone, even that 1600 milligrams wasn't making it for all the estrogen they had. But some people seem to be okay with that. There was a doctor named Don Colbert who I've never met. He didn't use our pharmacy. Wrote numerous books about using hormones in his practice. And one of his latest ones, he was talking about using more hormones than he had been using in the past, higher doses, and getting higher levels. And he said he himself had relief from years-long psoriasis by increasing his testosterone. So he'd get in the top tertiary of the level, and started raising his patients' hormones a bit. Most of their urgent symptoms were alleviated, but they were even healthier having the higher doses. So I think we still don't know the whole answer.
So there's at a sister group, AMMG, there have been over the last 2 years numerous lectures about not blocking or not using aromatase inhibitors and just letting estrogen levels rise in men to crazy heights, 150,
Right.
170.
Yeah, Dr. Rousier, and he has some good points, but I also have a bone to pick with him about progesterone in men, which he will not visit. He thinks men don't need progesterone. He forgets you have adrenal glands and endocrinology and mast cells and your brain and everything, and your Schwann cells all producing progesterone. So I think that is rather a nearsighted kind of situation. So I don't know about those estrogen levels, but I would think I would look at progesterone and actually see if the progesterone levels are normal or suppressed and use progesterone first.
Okay. There's another doctor there, Camarella, I think his name is. He does pellets only, and his goal is this is for males, 2,000 total testosterone, 150 to 175 in estradiol. So what do you say to the, I mean, this was everything we weren't taught. 20 years ago we were taught, get the testosterone levels to 1,500 and the estrogens to 0. So we know that's not right.
No, that's not right. That produces infertility in men. And men need it for their bones. You can't it is part of the bone remodeling nonetheless. And so men do need estradiol. At what level is a good question. I sort of had some trouble with pellets being so unremitting in their hormone delivery. That's not very natural. And the other thing, it seems to me, and I've just got this feedback secondarily from women having pellets, the usual progesterone dose they're given is 200 milligrams a day, but I'm running into lots of bleeders with that kind of dosing. If you're going so high on estrogen, you need to have more progesterone or you're going to have bleeding problems.
Well, my experience is the progesterone pellets aren't very effective, and so we don't use
I don't think there's a pellet for progesterone. It would be kind of big. Is there?
I've seen them advertised, but I've never used it. So
yeah. It would have to deliver quite a lot of progesterone to be any good at all.
Yeah. So, and what about, can you address briefly women who've had hysterectomies? The consensus is still, I mean, they come in here all the time. My gynecologist said I don't need progesterone because I had a hysterectomy. Can you
I know. I always say,
Yeah.
did your doctor pass his physiology course? I don't know.
Well,
So it's really then you've got to blame the Endocrine Society and NAMS for putting out that garbage. And they wouldn't have the hysterectomy in the first place if they had enough progesterone. So now they're being denied progesterone further And of course, then they're good for the drug market. Again, for the benzos, for the antidepressants, the sleep pills, the high blood pressure pills. That's what's going on here. When you have those patients and you want to start them on progesterone, make sure it's plenty of progesterone, and you want a half the amount of estrogen that they're using, as it'll blow it up so much.
Right. Right.
That's-
And can you get talk a little bit about high estrone levels versus estradiol?
Okay, we're not measuring that enough because that can happen, and people
I
think
measure
that.
I measure it in every one of my patients. We get that on everybody. So
And what are you seeing?
when the estrone levels get between up to 90 to 100, we sort of don't like that. So we try to steer them away from that. So we see it a lot more with the oral estradiol pills than with the transdermal.
Yeah.
Um,
Yep, I wouldn't be surprised, but that has to be taken into consideration. You need balance, or you need extra detox or whatever to help those women.
and also now there's my old timer's disease. Now I forgot what I was going to say. There's a couple of questions here. Can you address the statement using 3 potassium salts alkalinizing cancer patients?
Yeah, you can find them on the internet. I actually in the formula. If you look up Zeta powder, somebody's selling that from TC McDaniels. And the other one is, if you look up Max Gerson's potassium salt thing, you can also find it. Somebody's selling that on Amazon.
Okay.
Really, really nice formula. But TC McDaniel lost his wife early on to heart disease, and he practiced well into his 90s. He said now he was sorry he didn't know what he knew now to help his wife, but that was a cornerstone of what he was doing. Potassium is very, very needed for your heart.
Yeah,
What do you think about progesterone receptor positive cancer?
Cancer.
Cancer, yeah.
So John Lee said this, that it was a positive, and probably it can be a positive, that progesterone, if you use progesterone, it stimulates P17 gene, which stimulates apoptosis. You have a more favorable outcome if you have progesterone receptor positive cancer rather than not. So I believe it would be good. I also believe it's hard to find doctors who would go along with it, because nobody really looks into it, right? You have this, so let's just avoid it altogether, which is not a healthy state for the person dealing with cancer.
Yeah, they can take estrogen, they can take progesterone. What's going to be their bone health?
You could give them testosterone. There's I wrote a synopsis of this book. I forgot the guy's name, Ed something, and he wrote a book about testosterone with prostate cancer and breast cancer. And one of the things that happens in endometrial cancer, I have a paper on this. For endometrial cancer, as the cancer progresses, progesterone receptors recede. I think this work was done at University of California, San Diego. They were going to create a test so you could measure how bad the endometrial cancer was. In the discussion, the introduction to this particular study, they were saying something like 50–60% of women with endometriosis had been earlier treated with progesterone successfully, but now we don't do this. We go straight to hysterectomy. So declining receptors indicates increased cancer
Hey,
or endometrial cancer.
hysterectomy doctors have car payments too, So
Yeah, yeah. I'd like to bring up something else that if I can have a minute, back to that chart where we're all taught that progesterone has to decline at the end of the luteal phase to bring on bleeding. But when we're working with those PMSers, they could have symptoms 1, 2, 3 days into bleeding. And so we kept them at the high doses of progesterone. Their doctors just said, keep going. And there was regular as clockwork. They started bleeding on time. And I began to think that there's something else. Now, this is my little theory, but that it's like the area under the curve for progesterone. It's a secretory hormone. It prepares the endometrium to be secreted. So when women are started on progesterone, not stop progesterone, all of a sudden they're back asking questions like, why am I bleeding? They're bleeding because progesterone has caused whatever buildup you have there to become secretory, and you're getting rid of it. So we have this misconception that progesterone has to be stopped for bleeding to occur. Progesterone has to be there for efficient bleeding to occur.
Yeah,
To help answer Dr. Patel's question, in the cancer center, we are using progesterone in relation to even cancers that are progesterone positive with progesterone receptor positive findings. So again, with this theory, because progesterone, as we know, actually has an effect on the estrogen beta receptor, which is actually a protective receptor versus the alpha receptor for estrogens. But again, this is something that we're doing again under oncology, but there's a lot of scrutiny with this intervention. But in relation to what I have observed in the studies that we have done there, that this actually has not been aggravating these cancers. And again, be safe with the dosing, start low always. And we're doing this under oncology's guidance. So just be cautious, but it is being done.
Okay. Another question here is concerning your finasteride comments, does it apply to dutasteride as well?
As dutasteride is, yep. Use progesterone. What's wrong with using progesterone?
I'm reading
Yeah.
I'm reading the question, that's all.
Don't shoot the messenger,
Don't,
right?
don't beat the messenger here. So
yeah, which is a surprise to me because I see all these these doctors like embrace bioidentical hormones and pharmacies, and then they switch into synthetic for that. So why?
I don't know.
Yeah, V3.
You have to ask them.
Yeah.
Could something about could be fermented versus non-fermented soy? Does that make a difference?
I don't think so.
Okay. And the statement.
It does make a difference for whether it's suppressing your thyroid.
Mm-hmm. So Dr. Southern says she had a patient overdose on soy and developed breast cancer. So
interesting.
Yeah. So I don't know. So what is the consensus now on the breast cancer patients and treating them with estrogen? I know there was a lecture at AF4M this weekend where the instructor was very passionate about the fact that there's no reason not to use it. So what's your take on it?
As far as using it?
Yeah.
17 beta estradiol. Was that Lindsay Berkson?
No, I think it was Mindy. Somebody or
Mindy Pels?
Yeah.
Yeah, I don't know because some of Lindsay's stuff is tied up with 2-methoxyestradiol, which is a different story entirely.
Mm-hmm.
So I don't really think it's smart to be starving the body of all these hormones. Back to the one thing that even surprised me, this woman talking about empty estrogen receptors. creates inflammatory molecules. I tried to get her slides, but I wasn't able to get it on my app, so I have to go back and get it. So I'd like to dig into that a little bit more. So it
Remember who that was?
I'd have to look it up. I can email you.
Okay. Okay. Okay, anybody else have any comments or questions? So,
Yeah, I got one more question for you, Carol. Sorry. In postmenopausal women on BHRT, are you a proponent of having them cycle that or constant dose all the time?
Well, there's two camps, and I guess for no real good reason, I'm in the camp of not cycling. When somebody's cycling, cycle along with them. After ovulation stops, you really, actually Ray Peat said this too. What should a menopausal woman look like? The hormone levels should be like a young girl before menarche. And we don't know what that is for anybody, do we? Pretty much, we don't know. So, you would have, like robust adrenal hormones carrying you along.
Okay, yeah. I always thought that was the way to go too. I didn't understand. I actually ran into some women who actually wanted to cycle and get a period back because they were so used to it. But I have no opinion on that. I don't know. So that's why I would ask you.
Well, throw another wrench in that it's sometimes theorized that women, when they shed blood monthly, they're getting rid of excess iron,
Yeah.
and their heart attack risk is lower while they're still menstruating. If that would be true, it would be an argument for cycling.
Yeah, I think their argument was just that they were used to it.
Yeah.
And that was it. And it always made sense to me to just, static dose everything.
Yeah.
Wouldn't that be an interesting study to do?
Yeah.
There's so many interesting things we could study. It's just never ending. I've been at this over 30 years now, and I'm still learning all the time.
That's a good thing. We
Yep.
always
well, as my mother would say, you've been doing this long enough, you should know what you're doing by now.
Yeah, at least have a clue. Yeah. Might I ask about Wally?
Oh, I don't know too much what he's doing, except he's in Colorado Springs doing cannabis growing.
He's not doing he's not doing Women's International.
No, they sold out to Belmar.
Okay. Oh, okay.
Okay. Okay.
So, Carol, what do you think about use of genistein in patients then?
I'd rather use real hormones.
Okay.
So what do you say to those who say, I don't want estrogen, but I have hot flashes and night sweats and, What do you have a little remedy?
Well, first of all, with those night, I would look at the insulin glucose adrenal stuff.
Mm-hmm.
And see if there's weaknesses there you can address. So then you could trap me with adrenal adaptogens. Now, I like some of the adaptogens. I love licorice as an adaptogen. So we could argue the same thing. All the adaptogens have that 4-ring structure, like derived from plant cholesterol, the kind of thing.
Mm-hmm.
So I think it's like Alan Gaby called DHEA the biochemical equivalent of chi, but I think maybe it's cholesterol in that 4-ring thing that might be the chi.
Okay. All right. Anybody else have anything? Any common problems that you come up with with your perimenopausal patients, menopausal patients, common themes, myths that we were all taught that aren't so.
Oh, I have a little bit of news from A4M. ZRT Lab has announced that they're using LC mass spec in saliva testing and blood spot now. You realize they were using radioimmune assay or enzyme-induced assay, so hormones before were not necessarily 100% that hormone.
Okay,
I don't know what that's going to do to the field.
we'll find out. Okay, yes, and our A4M project was put on hold because of the, their big weekend here, but I think we're going to be back at it by the end of the week, and hopefully we'll be on their platform shortly. I figured after the first of the year now, so. Okay, and so Dr. Klatz put on here forum .worldhealth.net is free.
Yeah, you see it on my slide. I see some people starting to engage in some conversations. It's kind of fun.
Okay.
So that's the intent. We provide a platform for people to engage.
Okay, and yes, and we've been talking with some of the folks there to move our program over to theirs, and hopefully we'll gather a much bigger audience. So, hint, Dr. Klatz. So
Okay.
so okay. Anybody else? John, you got anything for us?
Wonderful talk. Thank you very much, Carol.
Oh, thank you.
Okay. All right. So everybody have a terrific holiday, however you spend it. And if you don't spend it, that's okay too. We will be here next week. We will have Damon Savala, so the husband, Dr. Damon Savala, and he does brain restoration. So it should be fairly interesting. I don't know what kind of audience we'll have the day after Christmas, but we will be here. And we're here those of you who are new, there were some names there I didn't recognize tonight. Please bring one friend. We are here every Tuesday at 8 p.m. Eastern, 5 p.m. Pacific. We've been here for well over 3 years. And hopefully with our new affiliation, we're going to have much bigger audience, and even more we'll have even more fun. So it was great seeing everybody. Here it is. It's MERT treatment, brain restoration clinic. That's what we're going to be talking about next week. So it was great seeing everybody this weekend, in person, not on a computer screen. So that was actually quite fun, and we had some good time, and hopefully we can do it again shortly. Okay. I am on tomorrow for research Health Alliance. Anybody wants them, I'm going to be talking about non-hormonal ways to raise or lower hormones. I usually get through in an hour. I go from testosterone through insulin. So we do the big 5 or 6. So different ways to manipulate hormones without using them, in case you don't want to use them, or your patients don't want them, or you don't have the credentials to write for them.
What was their name?
So
what was the name
of
the group?
Research Alliance.
Research Alliance.
Yeah. Okay. So send me an email and I'll get you the link if you're interested in that. That's 3 o'clock Pacific tomorrow, 6 o'clock Eastern. And we have Dr. Farshian's conference coming up at the beginning of February. And I'll be there also, and I know some of you will be there also. That's in Miami. So thanks everybody. Comments, questions? Anybody has anything that they'd like to present, please let me know. We will be here again next week, same time, same station. Thank you all for being here. Thank you for being with us all this time. I hope it's worthwhile. And I don't know who's yelling in the background, but and Carol, thank you so much. Do you have we always like a little summary. Do you have a little, going away? Like I tell everybody, my son was in theater for 20 years, and we always want him leaving the theater singing the songs. So what do you have?
Okay.
What do you have for it?
Well, my message is to train your patients to recognize what symptoms are what, and also to give them flexibility in dosing so they can address hormones. It's not like conventional medicine, you know, take one BID and that's it. Your body fluctuates, your hormones fluctuate, and I think patients should be empowered.
Okay, well, thank you for that.
Thank you. My pleasure.
Okay, and let's have a good holiday season. Have a great new year. And like I said, if anybody wants, so John, if you want to talk, I can kind of look up the link here, because I'm getting a couple folks saying they want the link. So give me 3 minutes to get that, and I will get that. So John, you know, do your thing.
Who, me?
Yeah, you.
What am I supposed to do?
Just talk.
Let's talk about the school. Any updates on the
Tell us
school?
about the school.
Well, I sent a message to Dr. Klatz tonight because he might be interested in some of the things we're doing. The key to the school is research, and we have a lot of members in our group that are producing products doing different types of medicine, and we might be able to link our research into the Caribbean, make it international, and that would then link to the school, which is being the research being done and directed by innocent students. Well, they're still young and innocent and have a lot of brains. So that's kind of what's going on with the school. If we approach the school, it will be through the issue of research, because they want to be advocates for medical students to do research. And the type of thing our group is doing surely needs research. I think we all agree on that.
Do you have an idea when they think they're going to be opening the school?
Yeah, it'll be 2 years, 19. The students will actually start pouring in 2025. So the first graduates won't come out until 2029, right? But in the meantime, they have to do their rotations, which they're always looking for. And we could help the students rotate through our various clinics. And then once again, I think it's important that they be directing the research, so they won't think we have a thumb on the scale.
Okay. It's a link for an email that goes right to their to a registration page. So it doesn't really give me a link. So anybody wants it, let me know and I'll send the email to you. Okay. So
Great.
all right, it's Allergy Research Group. So, and it is tomorrow. Okay.
Excellent.
Okay.
Thank you.
Okay. All right. So thank you all, everybody. Thank you for participating. Thank you for being with us, Carol. Great job. And we're gonna, you know, like I always say, I'm not very good at fixing things, so I only get asked once. So if we ask you back, that means you've been more than competent. So.
Oh, I hope you do. Okay.
Okay.
Bye.
All right.
Okay.
All
Bye.
right. So thank you all. We'll have the video up as soon as it's ready, usually within 24 to 48 hours. It'll be on our AOSRD website. That's AOSRD.org. One of these days we'll change it. It goes webinars. So it's either that one or on YouTube. I have it under my own name. It's Clearfield Medical Group on YouTube, and the videos are there also. Okay, so if you go on YouTube, like, subscribe, and do all that silly stuff that they tell you to do when you listen to a YouTube video. Okay, Thanks, John. Have a great holiday. Dr. Quinn, it was nice seeing you in person. Carol, thank you so much. Everybody else, have a great holiday. And again, if you want for tomorrow, Dr. Bill 9@gmail.com. Just send me a message and I'll send you I'll just forward the email that they sent me with the link. It goes right to like a registration page. So okay, it's Dr. Bill 19, not 2. I get all excited, There you go. Okay. All right. And everybody that was new, thank you so much for being here. Carol, great job. And we will be talking shortly.
Okay.
Okay. Thank you so much. And good night, everybody. Good night, John. Say hello to Sylvia. And everybody new again, thank you so much. See you.